So over to you. You may start the session.
Thank you. Good afternoon, doctors. I, Dr. Prashant, cordially welcome you to this webinar on influenza and its prevention by Heathrow. Heathrow Healthcare's journey began in 1993 with 30 years of excellence. We have got 300 plus products in our portfolio, presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARVs, APIs, and FDFs in the world. We have Asia's largest manufacturing facility complex at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties, pioneering in both quality and innovation. And we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneer in antiviral, introduced products like oseltamivir, favipiravir, and remdesivir, for which Heathrow received award for pharma excellence in August 2020 for COVID drugs. Today's webinar, influenza and its prevention. We all know the importance of influenza and its prevention of influenza, especially in children, because preventing influenza can avoid a lot of preventing influenza can avoid a lot of potentially avoid a lot of problems. And although there are many papers on necessity of preventing influenza and the role of oseltamivir, we also always like to get our own doctors' experience and insights into the disease process. For which today we have got two eminent speakers, Dr. Nageshwar Rao, Dr. Sachin Miraj. Dr. Nageshwar Narayan Rao is MBBS JNB Gold Medalist. Sir is PG DMCH, Indira Gandhi National Open University, New Delhi. Clinical experience is from Nice Hospital, Hyderabad, Mahavir Hospital and Research Center, Hyderabad, India, and Mahadeva Rampur Medical College, Gulbarga. Sir has trained several graduates from Care Hospital, Hyderabad, trained postgraduate students from postgraduate DNB students, trained nurses in NRP and neonatal nursing protocols, trained staff nurses in PICU instructor of, Sir has been instructor of pediatric advanced life support. Sir has performed several procedures both in neonates and in children and has presented in many seminars and conferences. Welcome, Dr. Nageshwar Rao.
Thank you, sir.
The next speaker. The next speaker today is Dr. Sachin Miraj. Sir is MBBS at prestigious Jawaharlal Nehru Medical College, MD Pediatrics at Bapuji Medical College, Davangere, certified in Pediatric Advanced Life Support, Pediatric Epilepsy Training, Asthma Training Module, Neonatal Advanced Critical Care, and has Best Paper Presentation Award, received Best Paper Presentation Award, National Respiratory Case Competition. Sir is the first pediatrician in Athani to start ventilator neonatal ICU, double volume exchange transfusion, delivered toxic speaker at Bharti Hospital, JNMC, Belgaum, MRMC, Gulbarga, KBN, Gulbarga, delivered toxic speaker at Bharti Hospital, JNMC, Belgaum, MT, MMC, Gulbarga, and KBN, Gulbarga. Welcome, Dr. Sachin, and I now hand over the session to Dr. Nageshwar Rao for further deliberations. Over to you, sir.
Thank you, sir. Thank you for the introduction. And I would like to thank Team Heathrow for providing an opportunity to share few of the information about the drug oseltamivir. So to start with the talk, we will like to share this PPT. Is the screen visible to everyone now?
Yes, it is visible.
Yes, sir. Very
Thank
clear.
you.
Yes.
Now we'll proceed with the presentation. So good evening, everyone. Presently, we'll have some insight into the etiology, pathophysiology of our flu infection and also how to treat those infections. So in this presentation, we'll be proceeding in the following format. First is the healthcare challenges in monsoon and their diagnosis, infection like influenza and its complication, clinical evidences of oseltamivir, and the guideline recommendation for the empiric use of oseltamivir. What are the guidelines for the use of oseltamivir? Coming to the healthcare related changes in monsoon, this simple flu-like infection can be simple running nose, cough, fever to severe infection. In even the patient can go into the respiratory distress, respiratory failure, and even on ventilator also. So this is the broad spectrum of the disease presentation, where it can range from simple running nose, cough, fever to a severe illness. So there are few studies which have been done with related to influenza virus. This is in relation to the seasonal variation. This study was done in Chennai, Tamil Nadu. This was a long period study. It has took nearly 7 years to show the results. This study was done by Department of Virology in 2019, and this was done at King Institute of Preventive Medicine and Research, where 36,670 specimens were subjected to the influenza analysis, and the duration was of the study was 7 years. In this, they have found that influenza positivity started with the onset of monsoon, and the infection has peaked during the post-monsoon months. So this study makes us alert when to suspect the flu-like infection, and when the usually lot of cases do come in the society at the post-monsoon months. So this is the overview of influenza infection in India. So the blue color bar diagram shows the cases of influenza infection. In the year 2015, 4,259 cases were reported, whereas in the year 2018 it was 15,266, and in 2019 it was 28,798. And similarly, the bar diagram on the right side shows the number of deaths due to influenza viruses. So it is a significant percentage of the population who are vulnerable to infection, like infants and geriatric age group, or people with some comorbidities or immunocompromised person, are at very high risk of having severe complication and even death in the secondary to flu infection. Then what is flu? This is one of the most common infectious disease which is caused by influenza viruses. As we all know, it is highly contagious airborne disease that occurs in the seasonal epidemics. Which season? It is mainly monsoon and post-monsoon months, and it usually manifests as acute febrile illness. It, as we told earlier, it can cause from mild illness to severe illness also. Serious outcome of flu infection can result in even hospitalization and death of the patient. So there are various type of flu viruses, namely influenza A, influenza B, and influenza C. Influenza A, it causes frequent epidemics and periodic pandemics. Frequent epidemics occur due to minor antigenic variation in the viral structure, whereas periodic pandemics are seen due to major antigenic variation. Similarly, influenza B virus, it can infect only humans. So there is local epidemics which can be caused by influenza B virus. Similarly, influenza C virus, it can infect both humans as well as swine. So influenza type C infections generally cause a mild respiratory illness, and any person or a patient who is affected with influenza C are not seen to cause any severe epidemics or severe form of disease. Presently, the circulating virus which is seen in humans at present is influenza A subtype H1N1 and H3N2. So next method is once the as a doctor, it is not only our duty to treat the patient, but our duty is also to prevent the infection also. Similarly, whenever a patient comes with flu, we should know the transmission of flu, so then we can counsel the parents and ask them to limit the transmission of flu virus. Similarly, how the transmission occurs, people with flu can spread its infection up to 6 feet away. So it is by the mode of coughing, sneezing, talking, screaming, and in our OPDs, even babies crying can also transmit the viruses into the air. And this droplet can land into the mouth and noses of the people who are standing or sitting nearby, and or possibly inhaled into the lungs if they are suspended in the air for a longer time. Hence, people should stay away from the affected person, and we should ask a sick person to stay at home so that he doesn't spread the viruses. And it is also important to wash hands often with soap and water. Whereas most healthy as adults may be able to infect the other people beginning one day before the symptom develop. and up to 5 to 7 days after becoming sick. It is not that after the person start with the symptoms of runny nose, cough, and fever, he has become infectious. He has become infectious and is capable of transmitting the infection 1 day prior to starting of the symptoms. Similarly, children may pass the virus as long as 7 days also. So this is one of the table where where with the symptoms of the patient we can differentiate whether it is influenza-like illness, whether it is H1N1, it is SARI or COVID-19. Almost in all the form of the flu infection, fever, myalgia, cough, lack and energy, and sore throat. These are the symptoms which are seen in almost all type of infections. Similarly, breathlessness may or may not be present in influenza-like illness, but it is definitely present in H1N1, SARI, and COVID-19 infection. Loss of smell and loss of taste, it is seen in COVID-19 infection. Diarrhea is seen in COVID-19 infection. Headache may or may not be present in influenza-like illness and SARI, whereas it is present in H1N1. It may or may not be seen in COVID-19. So any patient who has come to the OPD or we are seeing in an OPD, there are few warning signs which are to be noticed. Any children who is presenting to the OPD with fast breathing or troubled breathing, who is having cyanosis or bluish coloration of skin, who is not taking enough fluids, the child is lethargic and dehydrated, he is not waking up or not interacting, it means CNS is affected, he has become lethargic, being so irritable that the child does not want to be held. It is like inconsolable cry, and flu-like symptom improve but then return with fever and worsening of the cough, and any child with fever with rash. These are the children who has to be seen on priority basis, and we have to do early diagnosis. In addition to that, if we come across an infant like who is less than 1 year, along with the above symptom, we should also ask for being unable to eat. He is having trouble breathing. He has no tears while crying, and there are less urine output like oliguria is there. These are the warning signs in children and infants. Whereas in adults, any person who is present, giving a history of difficulty in breathing or shortness of breath, who is having pain or pressure in the chest or abdomen, who is having features of sudden dizziness, confusion, severe or persistent vomiting, again flu-like symptom that improve but then return with the fever and worse cough. These are the emergency warning signs where we have to be alert, thinking like it is severe flu-like infection. How this flu can complicate? It can become SARI, it can lead to pneumonia, bronchitis, ear infection, worsening of the disease in a patient who is already suffering from asthma or COPD, acute respiratory distress syndrome, or even death of the patient. So after knowing like in which season it can peak or in which season it usually present and what are the symptoms, how it transmits. Now, once we come across with a child or a patient with influenza, next step will be our management. So in management of influenza, there are two types of treatment. One is supportive treatment, other is definitive treatment. Coming to the supportive treatment, it is like asking the patient or a child to take bed rest, increase fluid consumption to maintain the hydration, use of cough suppressant if cough is more and the child or a patient is distressed, analgesics and antibiotics such as simple paracetamol to reduce the symptomatology, and non-steroidal anti-inflammatory drugs for use for myalgias and fever. Most patients will recover with influenza-like illness in 3 days. However, body pains, weakness may persist for weeks based on their immunity level. And severe cases may require intravenous hydration and other supportive measures. This is about the supportive care. Coming to the specific treatment with antiviral drugs for flu-like infection or influenza infection are divided into two. One is neuraminidase inhibitor and other is adamantinase. That is M2 ion channel blockers. The examples of neuraminidase inhibitor is oseltamivir and zanamivir, whereas the other group of drugs, adamantinase inhibitor, are amantadine and rimantadine. How this work? Neuraminidase inhibitor like oseltamivir and zanamivir, they block the viral neuraminidase enzyme which is present in the virus, which is critical in releasing virons from the infected host cells. Because whenever the virus enters into the host cell, it multiplies to thousands of times, and with the neuraminidase enzyme, it tries to digest the cell wall of the host and causes release of virus. So these neuraminidase inhibitor are active against both influenza A and influenza B. Whereas in adamantase manganese inhibitor, they interfere with the hydrogen ion channel activity of the influenza A virus. Thus, it blocks the entry of virus into the cells. And these drugs like amantadine and rimantadine are active only against the influenza A virus. Coming to antiviral therapy with oseltamivir. Oseltamivir drug as such is a selective inhibitor of neuraminidase enzyme, as we have seen in the previous slide. It is active against both influenza A and influenza B. This oseltamivir, it is a prodrug. Once which enters into the body, it is converted into the active form by the liver. It inhibits the virus replication and pathogenicity, and hence prevents the further spread of infection. It is active against all the strains of influenza A and influenza B. Whenever you are not sure whether it is influenza A virus, influenza B virus, it is better to start with this drug. So this is a diagram showing how this neuraminidase activity is inhibited by oseltamivir. Oseltamivir was the first oral neuraminidase inhibitor, and presently this drug is approved in more than 100 countries to be used against the influenza infections. So this is a drug dosage. In adults, it is 75 mg capsule twice daily for 5 days for the treatment. If you find any close contact or any susceptible person with any pre-existing illness like asthma, COPD, or any person with chemotherapy, we recommend oseltamivir chemoprophylaxis, which will be 75 mg capsule once daily for 10 days. When coming to the infants, less than 2 weeks to 1 year of age, if you come across any child with 2 weeks to less than 1 year of age, the dose to be calculated as 3 mg per kg twice daily for a therapeutic like treatment dose for 5 days. So prophylaxis is not recommended in such a small age group. Whereas coming to the children who are weighing less than 50 kgs, it is 60 mg per kg in 2 divided doses. In between 15 to 23 kgs, it is 90 mg per kg per day. 23 to 40 kg child, where recommended dose is 120 mg per day in 2 divided doses, and child more than 40 kg, it will be like similar to the adult dose. It is 150 mg per day in 2 divided doses. In any of the above 4 age group, if you want to go for prophylaxis, again it will be half the dose, and the duration will be double, like it will be 10 days. So in a few selected cases where the post immune responses are very less, then in such cases we can continue prophylaxis up to even 6 weeks or even 12 weeks also. So what are the clinical trials where benefit of empirical and early use of oseltamivir has been shown? This oseltamivir has been said to be a wonderful drug for walking pneumonia. So this few of the case scenarios we will discuss later. So there are few studies which have shown that oseltamivir treatment with influenza-like illness reduces the long-term use of antibiotics, prolonged hospitalization, and lot of morbidity also. So with the early start of oseltamivir, the antibiotic use was reduced by 26.7%. Similarly, influenza-related complications and antibiotic therapy by 55% and hospitalization by 59% with early use of oseltamivir. There was one more retrospective study which has shown where they have reviewed 442 patients. Of that, median time from symptom onset to oseltamivir administration was 5 days. And here, the subjects were divided into 4 groups based on the time where the oseltamivir was introduced in their treatment protocol. One group was having the oseltamivir was started early, like less than 2 days. One group was between 3 to 7 days of onset of illness, and other was 8 to 14 days, and fourth was more than 14 days. In this, they have seen that the probability of and severity of pneumonia and the probability of severe pneumonia increased gradually with the time from onset of symptom to oseltamivir administration. Hence, earlier initiation of oseltamivir administration after symptom onset significantly reduced the occurrence of pneumonia as well as severity of pneumonia. Along with that, shortened hospital stay due to pandemic H1N1 in 2009. Along with that, even when administered 48 hours after onset of symptom, oseltamivir showed considerable potential for reducing pneumonia. There may be fair case scenarios where the patient, if comes to us as a first physician, then based on the present epidemic, we can start oseltamivir. If the patient has not come as an initial at the initial stage, and if he has presented to us like on a third day, fourth day, there is no harm in starting oseltamivir at that stage, and in fact, it is more useful also. So this is a bar diagram where it shows that oseltamivir administration patients were discharged earlier from hospital due to early recovery. There is one more study where, along with that oseltamivir, they have added azithromycin as a combination therapy to reduce the secondary bacterial infection. So in that, again, the influenza A infected hospitalized patients were divided into two groups. One group was 227 patients, other group had one or two patients. Where in group one with 227 patients, oseltamivir and azithromycin, both combination therapy was given for 3 to 5 days, and then second group only oseltamivir was administered for again 3 to 5 days. In the both of the groups, oseltamivir azithromycin combination therapy has reduced the secondary bacterial infection on these patients, and they required less respiratory support, and these patients recovered early. Again, this is same bar diagram which shows that there is a significant reduction in the hospital stay and influenza symptom severity score when the combination therapy was given. So, what are the guidelines to start the oseltamivir now? World Health Organization recommends empiric treatment whenever you find such a patient. And treatment should be started as soon as possible, because in the previous slide we have seen that earlier introduction of oseltamivir has reduced the morbidity, mortality, and prolonged hospital stay, and those patients recover early. Similarly, lab confirmation of influenza virus infection is not necessary for the initiation of treatment, and the negative lab test for H1N1 does not exclude the diagnosis in all patients. Hence, therefore, if you find any high-risk individual who has exposed to the patient with influenza, consider presumptive therapy with oseltamivir for early recovery. Again, Government of India, Ministry of Health and Family Welfare states that empirical therapy includes a neuraminidase inhibitor for treatment of influenza, where there is a local circulation along with other risk factors. Similarly, in adults, it recommends that the anti-influenza treatment such as oseltamivir be prescribed for adults with community-acquired pneumonia who test positive for influenza in the inpatient setting, independent of duration of illness before diagnosis. And this recommendation comes as a strong recommendation with moderate quality of evidence. So, if a patient has presented to the hospital on somewhere around fifth or sixth day when his condition has deteriorated, at that stage also, it is recommended to start oseltamivir. Again, several observational studies suggest that the treatment with oseltamivir is associated with reduced risk of death in patients hospitalized for community-acquired pneumonia who has tested positive for influenza virus. Again, treatment within 2 days of symptom onset or hospitalization may result in the best outcome, although there may be benefits up to 4 or 5 days after the symptom begin. So, if you find a patient presented to you lately, but still he is positive for influenza, then it is better to start oseltamivir. So, to summarize, proper diagnosis can and early treatment prevent flu-like complication. Empiric use of oseltamivir reduces lower respiratory tract complications, reduced hospitalized stay, and reduced antibiotic use. And World Health Organization and American Thoracic Society and Ministry of Health and Family Welfare recommends empiric use of oseltamivir in a required population. So this was few information about the oseltamivir. Now I'd like to hand over the further proceeding to Dr. Sachin.
Thank you, Dr. Rao. Thank you for your insights.
Thank you, sir.
We'll wait for Dr. Sachin to share his screen.
Yes.
Dr. Sachin, sir. I think sir is on mute. Oh, here. So can you please do it in presentation mode?
Yes.
Thank you, sir.
Yeah. Hi. At the outset, I would like to thank the organizers for giving me opportunity to present this case scenarios. As we are seeing a lot of cases of influenza nowadays, it is an apt time to present a few case scenarios about influenza. I think most of us, day-to-day practice, come across a lot of kids with respiratory symptoms. Even though we see a lot of cases who come with complaints, very few patients have been classified and very few are getting the appropriate treatment. To begin with, I would like to go across some very common presentations in our OPD practice. So this is about a kid by name Dia who presented to OPD with cold for 2 days, mild fever. She sneezed a lot and she had some stuffiness of the nose. Now, let's think about it. Does this kid fall into the category of influenza? Uh, when she and as we saw, we put her on antihistaminics and paracetamol. She made a good recovery within a few days. So this is the kid which comes to you with the common presentation called common cold. So does this qualify for influenza? Because there is a lot of confusion among the practitioners whether to call it as flu or just a common viral illness. So now this case, second case, will throw a little bit more light on the same issue. So this is a 3-year-old boy by name Arush who came with very high fevers on day 1. So he had a lot of chills and he looked toxic. He also had severe headache. He had a lot of body ache. He had myalgia, lethargy, and mild cough and cold. So as the days progressed, we treated he was treated symptomatically with paracetamol and antihistaminics, but it worsened over the next 2 days. He was quite lethargic, and he had received IV fluids elsewhere. Because on date of exploration, because of high fever and lethargy and mild tachypnea, he was received to our hospital. So now, this is a very important scenario just to put it into perspective. When the symptom profile is similar, that is, they all have fever, cold, cough, and some systemic symptoms. So first thing is, any viral infection, it presents with a generalized onset. So that is very important to note that they will have cold, cough, fever, sore throat, and other systemic symptoms. So, but when do we call it as influenza and when do we call it as common cold is what we are supposed to do at the point of OPD. That is, when a child comes with lot of headache, lot of myalgia, and he is lethargic, or he comes with an explosive fever and he has a lot of chills, these symptoms favor a diagnosis of influenza. While if child has lot of sneezing, lot of nose stuffiness, but mild fever, then he fevers more to be a common cold. So this is a very important take-home message. That is, low-grade fever, gradually evolving complaints, sneezing, stuffy nose, sore throat, these favor common cold. Abrupt onset, high fevers, chills, lot of body ache, headache, and progressive to chest discomfort, tachypnea, these favor diagnosis of influenza. So this is the drive home message of when to consider influenza. Now, why is this important? Because considering that oseltamivir, we have gone through the discussion, oseltamivir is a wonder drug. It has a beautiful action, and lot of kids who have received it, there is dramatic change in the symptoms. But we have to know on for whom to start this drug. So this slide is a crux on which we have to decide whether to start on oseltamivir or not to start. Coming to the second thing, now what happened to that kid was his symptoms worsened. His SpO2 was 94, his RR was 22, which was on the higher side. So chest X-ray was done. It showed peribronchiovascular cuffing, and there was consolidation central and mid zone. So at this time, a drug of only paracetamol and oseltamivir was started after sending swab, and the child improved dramatically in the next 2 days. So this is very important again. When there is an X-ray which looks like this and symptoms which favor the clinical profile, then you are valid to start only oseltamivir without starting any antibiotics. We took the brave step and started on only oral oseltamivir, and the throat swab luckily came out to be positive. So this is another important message, that is, we need not treat every respiratory illness with antibiotics. Lot of the illnesses are viral. Most of them require symptomatic treatment with good hydration, and few cases will require an antiviral drug when we are considering flu as our diagnosis. Now, we'll go to the third case. This child, a 4-year-old child, came with a history of fever since 3 days, gradually increasing, later developed productive cough. For the next 2 days, now he came with right lower chest pain. He walked in the OPD with a stooping posture. He was holding his chest. When we examined, there was reduced air entry, there was creps, there was dull note on percussion, and his chest X-ray was done, which showed lobar pneumonia. So this kid, what we can notice is how to differentiate between a viral pneumonia and a bacterial pneumonia. While viral pneumonias or influenza pneumonias are abrupt in onset and have a lot of systemic symptoms, kids with bacterial pneumonia evolve gradually, and at the peak they develop productive cough and there is localized symptom. While influenza involves both the sides of the lungs, the pneumonia, which is bacterial origin, usually localizes itself to one area. So this patient, clinically we could make out that he had stooping posture and he held his chest. This favors that he has a pneumonia in one particular area. Decreased air entry, creps, and dull note of percussion again favor the same thing, which was confirmed by the chest X-ray. And he responded very well to ceftriaxone, and oseltamivir was not recommended for this case. So the first point is differentiate between common cold and influenza. Second is influenza and pneumonias. Now, very important take-home message is productive cough, gradual worsening, sporadic chest pain, unilateral lobar findings favor bacterial origin, while abrupt onset, systemic symptoms, bilateral, asymmetric distribution favors influenza illness. Now, the final very important case scenario is a 2-year-old kid who is a known case of CHD, present with abrupt onset fever, was looking ill, drowsy on day 3. His swab was sent, chest X-ray was suggestive of influenza. He was put on in oseltamivir. As you all know, oseltamivir is a wonder drug which shows action in a very short period of time. Within 2 days, the child showed good improvement and he went home against medical advice. But the point is that he has to take a proper course of treatment. As he was okay and he was a known case CHD, parents were already fed up with his current illness, they left the treatment. Later, he again started showing features of fever, the cough, progressive increase in respiratory problems. This time, he again came back to hospital when it was noted that he was having a very bad lung picture. So the another take-home message is that even though at one point he must have decided that no, this is influenza and not bacterial pneumonia, it is very important that we keep a high risk approach. We screen the patients and follow up for longer duration. There is high likelihood that there can be co-infections and post-influenza secondary bacterial pneumonias. So the important point is to differentiate between cold, influenza, bacterial infections, and secondary bacterial infections. A very important point is that there are some patients for whom we are supposed to start treatment quite early. Those are those kids who are less than 2 years, sick and inborn hospital patients, immunodeficient kids, those on steroid prophylaxis, obese kids, And those who have chronic illness like CHDs or nephrotic syndrome or asthma, such kids will require prophylaxis earlier. The important point is these patients who are considered to have walking pneumonias should receive oseltamivir as a drug of choice. I hope that I have made sense to you, and I hand over the proceedings to the team. Thank you.
Thank you very much, Dr. Sachin. It was wonderful, knowing the differential diagnosis and I mean, clinically how you do it. Laboratory, until the laboratory reports come, at least we have got some sense of, knowing what the infection is. It was
Yes.
lovely. It was lovely. I mean, you beautifully put it, a very simple term you put it. Beautiful. I'm sure the audience must have benefited out of it. What do you say, Dr. Rao? It was indeed beautiful.
It was all case scenarios were like differentiating.
Yes, sir.
Viral, it is common.
I had a feeling in my third MBBS, asking differential diagnosis, beautifully explained.
The aim is to just so that we
Yeah,
do something
exactly.
clinical so that they people know when to
Yes.
use it and
And it's
how
important
long to use it.
exactly important to get this feel even before the laboratory investigations come, because at many
Yeah,
places
because
it may not be available. Yes,
it may not be available and it is not
Yes.
required every time.
exactly,
Not
exactly.
required every time because we have to start it earlier.
Correct.
The point of starting oseltamivir is to start early so that the symptoms are the treatment is started before it progresses.
Correct. Lovely. Thanks, Dr. Sachin. Thank you, Dr. Rao. Sir, you can stop sharing.
Sir, excuse me, we have a few questions from the audience.
Yes.
Dr.
Yes, sir.
Kayyum wants to ask, what is the criteria of steroids in influenza in pediatrics?
Sir, can I take it?
Yes.
Yes. So, as such, any bacterial or viral infection, steroid is not the drug of choice and need not be used. Steroids are the drug of choice for allergic or immune-mediated conditions. So these are infectious. So at any given time, as a pediatrician, it is our role to identify whether we are dealing with the infection or a immune-mediated condition. So if it is a child who has lot of tachypnea, lot of respiratory distress, but there is no fever, then it favors a bronchitis sort of thing. It can be allergic in origin, or he might be a known case of asthma. So in kids who are diagnosed with known case of asthma, or the conditions favors an allergic sort of presentation, then we advised we can give him steroids. But when we are dealing with a child who is having an influenza, that is, he has very high fever and he is quite lethargic, there is no role of starting steroids in such kids. And I would rather say stay away from it because we might as well, because once the kid suffer from influenza, his immunity on the lower side, and we are giving him steroids, he might again be predisposed to a secondary bacterial infection. So I think we should steer clear of using steroids in kids who are presenting with fever and respiratory distress as the complaint. While no fever and more respiratory distress, steroids can be used judiciously.
Thank you so much. So the next question from Dr. Kayyum again.
There are two more questions, sir.
Yes. Role of antibiotics. You take somebody? Yeah. Okay. You can.
Role of antibiotics in antiviral in flu.
Sir, again a valid question.
I think, sir, there's some network glitch.
In the meantime, we can go to the next question. Dr. Nandakumar Rawal. Sir,
Yeah.
So, hello.
Yeah.
So that's the thing. As a pediatrician or physician, to a certain degree of confidence, we can start antivirals or antibacterials based on the clinical scenario.
Correct.
So there are some very clear defining conditions. Like again, as I mentioned, if there is abrupt onset, high fever, and child has come with complaints which favor a influenza-like illness, with reasonable confidence, we can start only antivirals. if the child has come with gradual onset of symptoms, he has a typical stoop, he has pleuritic pain, with great confidence we can consider using only antibacterials. So there are very few conditions which fall under the gray zone. In such a condition, we can, for the benefit of doubt, in a high risk kid, we can start both. So ideally, let's try to identify the symptoms and put them into categories. If they fall into the watershed zone, then we can think of doing a combination therapy. I hope it's clear.
Yes, thank you so much. There is, the next question is the role of steroid in flu or any viral infection. It's more or less the same that you. How to cope up with adverse effects of oseltamivir and other antivirals?
So Nageshwar sir, you can take it, sir.
Yes, sir. Most of the time, these antiviral drugs, when given in the recommended doses, like what has been shown in the slide, most of the time they do not cause any side effect. Of the late, if the child has symptoms, it can be simple gastritis. Other things like rash and any anaphylaxis like reaction, other things are not seen in the oseltamivir if given in the recommended doses. If the child is having vomiting or gastritis like symptoms, then we can add some antacids to the ongoing treatment.
Thank you so much, sir. Dr. Nandakumar Rawal's question is almost answered by Dr. Kayyum.
Honestly, I think both of us can agree that we have hardly seen any side effects from oseltamivir in our clinical practice. It is quite rare, and we had one kid who had taken larger quantity also, and but we did not see any side effects. I think it's relatively a safer drug. We monitored him for any behavioral change, because there are there are side effects of hallucinations and abnormal behavior, confusion, dizziness, as these are mentioned as side effects in the profile, but they are less than 1%. And even in my practice, I have not come across any of these side effects. So I think it's a relatively very safe drug and can be used easily by any one of us. Thank you.
Compliance is also good.
Dr. Sachin, can you share slide number 9?
Yes, ma'am. Anything in particular?
No, sir. This addresses all the questions, Dr. Khandepadkar, sir.
Yeah, this
All
addresses
the questions are
Yeah.
almost.
Yes.
Once again, thanks, Dr. Sachin, Dr. Rao, for your insights and for this. It's so wonderful, I'm getting practical insights into the complicated theory of a viral infection. It's not so easy to diagnose a viral infections. Thanks you so much. Thanks all the doctors for your questions and for your active participation in this webinar. Thanks marketing and sales team of ITRO for conceptualizing and operationally. Last but not the least, thanks Shashidhar and IT for IT support. Thanks all of you. We can sign off. Wish you a very pleasant evening and happy Sunday. Thank you, sir.
Thank you, sir.
Thank you. Thank you.
So thank you very much. Thank you very much. It was a very wonderful session and a lot of interactive and questions they had come up and handled very well. So again, once again, thank you very much for this, sir.
Thank
Good
you.
day, sir.